A 58-year-old female presents with acute-onset pleuritic chest pain, shortness of breath, and mild hemoptysis. I am showing you two slices of an axial contrast, enhanced chest computed tomography scan. Describe the findings.
The axial contrast enhanced chest computed tomography scan slices demonstrate a peripheral, wedge-shaped consolidation abutting the visceral pleura.
This consolidation contains multiple small, rounded central areas of low attenuation, and there is a prominent feeding vessel directed toward its apex.
The key differential diagnoses include a pulmonary infarct, acute bacterial pneumonia, pulmonary hemorrhage, and a peripheral neoplastic lesion.
If I tell you the patient underwent a total hip replacement 2 weeks ago and has been immobilized, which of these is the most likely diagnosis?
With that history of recent major orthopedic surgery and immobilization, a pulmonary infarction complicating acute pulmonary embolism is the most likely diagnosis. The computed tomography vessel sign and central lucencies strongly support this.
Describe the computed tomography findings of central lucencies and the vessel sign in pulmonary infarction, and explain their significance.
Central lucencies are rounded, non-enhancing areas of low attenuation within the consolidation, representing spared lobules or early necrosis. The vessel sign is a feeding pulmonary artery branch directed toward the apex of the wedge-shaped consolidation. Both findings are highly specific for pulmonary infarction.
Why is pulmonary infarction relatively uncommon in patients who present with pulmonary embolism?
It is uncommon, occurring in only 10 to 15% of pulmonary embolisms, because the lung tissue has a dual blood supply from both the pulmonary arteries and the bronchial arteries, which protects it from ischemic necrosis.
Under what predisposing clinical conditions is pulmonary infarction more likely to occur following a pulmonary embolism?
Infarction is more likely when pulmonary arterial occlusion coexists with compromised bronchial arterial flow or elevated pulmonary venous pressure, such as in patients with congestive heart failure, chronic obstructive pulmonary disease, or mitral valve disease.
State the classic radiographic signs associated with pulmonary venous congestion or pulmonary embolism on a chest radiograph.
Classic signs include Hampton's hump, which is the wedge-shaped pleurally based opacity, Westermarck's sign, representing focal oligemia distal to the embolism, and Fleschner's sign, which is a dilated main pulmonary artery.
What is the melting sign of a pulmonary infarct, and how does it help distinguish it from resolving pneumonia?
The melting sign describes how a resolving pulmonary infarct shrinks from its periphery inward while maintaining its original wedge-like shape, similar to a melting ice cube, whereas pneumonia resolves in a patchy, disorganized fashion.
What is the estimated prevalence of incidentally detected acute pulmonary embolism on routine chest computed tomography scans in oncology patients?
The prevalence of incidentally detected acute pulmonary embolism is estimated to be between 1% and 5%. In contrast, enhanced computed tomography scans performed on oncology patients.
State the critical safety warnings associated with a pulmonary embolism and outline your management recommendations.
The critical safety warnings are acute right ventricular failure, hemodynamic collapse, and recurrent embolization. Radiologists must immediately notify the clinical team, recommend urgent therapeutic anticoagulation, suggest systemic thrombolysis or catheter-directed thrombectomy if the patient becomes hemodynamically unstable, and recommend genetic screening for inherited thrombophilia. Refer to respiratory medicine and intensive care.